creates an ACS surgeon, right? Creates an acute care surgeon. And so this is all about then cultivating a complete skill set in the right environment, right? In this place that has the administration that's willing to support, the technology that's necessary to provide the activity and the skills, the safety of a critical care unit, and colleagues that you can lean on, that you can go to sleep at night knowing that your patient's well taken care of because those are your partners. That's what it takes to be able to provide these therapies. That's the sort of skill set and team that is really necessary to be able to provide the entire breadth of intervention that these patients need. So how do we get there? Well, we've been talking around complex PCI for years now, right? The first CHIP fellowship was in 2015. And we're in 2022. Let's say we discount 2 years because of COVID. So how many left mains should you do before you're ready? How many CTOs should you do before you're ready? What about how many epicardial collaterals should you be able to wire before you say, I have them? It's time for standards. It's time for a stake in the ground to say we are going to commit to doing this right. And we are going to commit to the idea that we are going to demand the basics to be able to advance. And so this is the future, right? This is currently under review, okay? And I'll tell you the honest to goodness truth. This paper has been reviewed and rejected and reviewed and reviewed and reviewed over and over again by real winners in this space, because everybody gets very uncomfortable with this idea of standards. Nobody wants to say, we don't have enough of that volume at our site to be able to call ourselves a level 1 center or a full CHIP center, right? And so perhaps this is the time where we all need to coalesce together as a community to focus on patients and what patients need as opposed to what our own centers can provide. This is by no means the guide. This is an example, right? This is our spitball. Where we started, no doubt this is going to refine itself. And these are then the operator targets, right? These are the institutional requirements that are necessary to create these level 1, never need to transfer centers, right? You're not going to do a super complex PCI in a center that has no critical care backup. That's unsafe, right? And so we then need to try to concentrate these types of cases in those centers with the operators that are trained to do them. And that doesn't mean that if you work in a small center, you can't be the one to do the big case. You can. That's the paradigm shift, right? Away from us towards what our patients need, and making sure then that the providers that have those relationships with those patients are the ones that actually provide the care. So this is an example, one spitball of an on-the-job training pathway. This has since been modified a bunch of times, so what's coming out in the literature will look a little bit different. But in summary, complex PCI, high-risk PCI is here to stay, right? It's not about one procedure. It's not about some magical characteristic that makes a PCI a complex and high-risk PCI. It's about layering skill set upon skill set, partnership upon partnership in the right environment to be able to do one simple thing, which is do whatever our patients need. That's why we exist, that's why we're here. With that, thank you for your time.
Thank you very much, Dr. Karla. Now we're going to start the session, today's first session. 40. 40 means tips, tools, technique, and term for complex PCA. The chairpersons are Professor Jamal, Professor Jamal, Director in SBD. And panel of expert, we have Professor Ashok Kumar and Dr. Asish Dey. And moderator, along with me, Dr. Nur Alam, please come into the dais and take your seat, please. Dr. Asish Dey here.
Thank you, Dr. Shafique. May I request our first speaker, Ramesh from USA, who will give talk on framework building key elements of a complex PCI program. Ramesh Dagubati.
That's good. It's working. No technical difficulties so far. Congratulate Dr. Azam for inviting all of us for this program. We have learned about state-of-the-art lecture by Sanjog, a fantastic talk on how to do a chip program. So when you talk about complex PCI, what is complex for me may not be complex for our chairpersons here, right? So complexity depends upon where you are in your training, how many have you done and complex procedures, and what type of support can you use. Yesterday someone asked me, I think my colleagues from Italy and Turkey, Dr. Shaiban and Dr. Doktikin asked me, you use a lot of impellers in America, why? Because we can make complex procedures into simple procedures. So you can actually take a simple procedure, type a lesion, and make it more complex by creating complications. So that's not what we're talking about. We're talking about truly what is complex. So what patients are we talking about? This slide you have already seen by Dr. Kalra, that actually looking at patient comorbidities, coronary anatomy, and also what are the other events such as heart failure and hemodynamic parameters. So there are several things that we look at, right? So these are the chip programs. And the key elements of a complex PCI, when we talk about it, one of the things is the patient improves outcomes. In the United States nowadays, a lot of importance is given to quality. If somebody has an acute MI mortality of more than 5%, they are already a red flag. And if their mortality goes up by 2 standard deviations, meaning about 15% and higher, they might lose privileges from doing an acute myocardial infarction. So quality is very important. The patient, partners, imaging specialists, understanding how you can use imaging and physiology, and who takes care of the patients afterwards, intensivists, cardiac surgeons, structural heart disease specialists, all of them are important. The dedicated chip operators. In our institution, we have 5 interventional cardiologists, 3 of us are structural, 2 of them are actually chip operators, so they deal with only chip. And everyone does obviously the simple procedures. It's a teaching and research, whether we can include clinical trials, live cases, and training programs such as this to say how to make a complex PCI into simple, and administration. One of the procedures that my colleague did, it took 14 hours for a PCI. It's a complex PCI. Obviously, it became more complicated and they had problems as well. So administration has to understand that you're blocking the lab for 14 hours is not acceptable, right? So you need to say that there is a dedicated cath lab as well, dedicated staff, and maybe one procedure day, maybe a Friday afternoon or morning, make it a chip program day. And you have to be very proficient in large bore access. So let me show you a few cases and then I'll tell you what are the elements. A 72-year-old man with AFib, he had bypass, all the grafts are occluded, he had ejection fraction of 20%, several admissions with non-ST elevation MI, and now he came in with urgent cath, ongoing chest pain, blood pressure was 67/38 prior to cath. This is back in 2015, so I'm going to show you some old cases as well. So here is this left main which is completely occluded. That was seen the same in 2014, and there are no other vessels. Everything is being supplied by this left main, collaterals to the right coronary artery as well, and you can see very clearly. So if the left main, if somebody is not very comfortable in saying this is a significant left main, so this is a left main suboptimal injection because we didn't want to engage. Blood pressure was dropping, so he had a very tight distal left main. So we did a final angiogram, as you can see, with an impeller, and we already had an ICD placed, and with an impella we were able to do a nice torsional stent technique in this patient. So the hemodynamics are very important. When we place an impella, we just don't place an impella and forget about it. We look at the Swan-Ganz catheter numbers, we look at cardiac power output, and we say what is actually the left ventricular stroke work index. Even without an impella, with a balloon pump, you can put a Swan, look at the left ventricular stroke work index, and normally it should be 30 and above. In this patient, it started at 15. So the stroke work index is important, and once it is more than 25, we were able to wean off the impella, or in the current situation in Bangladesh, you can wean off the balloon pump on that. So this is another patient with the CTO, PCI, and the dual catheter injections, and so afterwards a successful PCI. So what is the key element in these two patients? Good guide catheter support. In the left main, you need to be making sure you don't engage too deep. And in a CTO, you have to use dual catheters for CTO. Radial or femoral really does not matter. We can debate how much ever we want. I'm a radial operator. We do mostly 100% radial procedures in our hospital. But I actually do mostly distal radial. My colleagues do proximal. But we were never able to prove that actually radial and femoral is still a debate. And it is not that I can support that only radial should be the way to do all these PCIs. So this is another patient of a bifurcation PCI, and as you see again there's an impella, but post PCI is a very good result. And this is another CTO again here, you can see, and excellent result with the CTO. So here the patient also had a left main, but it was not significant by physiology. In these two cases, what do we learn? Guide wires. Different guide wires for different ones. If you want to cross a side branch, you need to have a very nice, soft tip wire. Whether it is a visco wire, that's what I like to cross my side branches, a circumflex after stenting the DK crush stent, after stenting crushing the stent in circumflex and recrossing, or you can use a pilot 50, whatever run to do what we want to use. But there are, for CTOs, you have different wires as well, Dia 1, Dia 2, Dia 3, and or you can use a Fielder XP and or a Visco wire to do anti-weight dissection PhD, which we'll learn about all that today. There are specialty wires, and for tracking, sometimes you might have to use a wiggle wire. So those two patients I showed you to understand the importance of wire, knowledge about wires, and improving on that. So complex patient. You can do a complex PCI, but the patient should not be complex. If the patient is complex, even a simple PCI in the complex patient becomes a complex PCI, right? Anyone with a cardiogenic shock, acute myocardial infarction, non-STEMI, we are quoting a mortality of 50% in a patient with STEMI and cardiogenic shock. How is that even calling a simple lesion of proximal LAD? No, it is not. Patient can really have low reperfusion, myocardial reperfusion injury, ventricular fibrillation, and die right away. So you have to be worried about that, and who will develop renal failure. So here are some more cases. Another patient with a dyspnea with a severe 53-year-old Caucasian male with severe COPD, oxygen-dependent tobacco abuse, and obviously these are very complex patients that no surgeon is going to touch them at any given point. He was found to have a 70% left main and a 50% ostial and proximal LAD disease. ECG does not show really anything, and his survivability is okay. So in this patient, you look at this, I mean, it's very difficult to say that there is a lesion anywhere, right? But look at, there is no reflux. When you inject the left coronary artery, there is no reflux. So that indicates that the left main is a significant lesion, right? And if you have a doubt, you can see one more picture again, there is no reflux. And when you do an IVUS, this left main is very significant, as you see, it's very small. So then actually with an impella, because the patient was surgically turned down, and we did a left main, and you can see it is extended all the way into the ostium, the stent, and beautiful reflux you can see, and now it's engaged as well, and you don't have any problem. So reflux of a catheter injection is important to know how severe it is. I think that's my sign. The key element is IVUS or OCT or FFR in these patients. Prepare the lesions. Lesion preparation is very important. Without a rotablation like in this patient, we would not have been able to achieve a successful RCA PCI as well. This is another patient with a severe complex RCA calcified lesion. We did orbital atherectomy. The previous patient had a rotational atherectomy. So it is important to understand how to do atherectomy. This is orbital, which probably we don't have in this conversation. So in view of time, I'll say quickly, here is a 90-year-old Chinese woman, again complex left main PCI, which was successful with the impella support. You need to use Swan-Ganz catheters. The key element number 5 is use balloon pump, tandem heart, or impella, or whatever you want, but you need to base that on a Swan-Ganz user. So please use Swan-Ganz in most of these patients. The guidelines are changing. Nowadays, most of the complex PCI also can be dealt with